Right. Hello, everyone, and welcome back to another virtual shouting session at Hearts for Health. Today, we're joined by Dr. Hobbs, who's a practicing periodontist with over 25 years of experience, who served as former president of the North Carolina Society of Periodontology. As a quick reminder for new participants listening in, we'll have a Q&A towards the end of the session, so feel free to type in any questions you have. And at that time, during the end of the Q&A, or during the end of the session, we'll have that Q&A where we're going to go through those questions. Also, to stay updated with future shadowing sessions, follow us on Instagram, where we post flyers for upcoming shadowing sessions and other program announcements too outside of shadowing. That's one way to stay in contact and stay tuned with us. Another way is through our listserv, where we send out announcements for future shadowing sessions. To join our listserv, just subscribe to our website at the bottom of each page. There's a subscription form. If you put in your name and your email, you'll be able to subscribe and you'll receive weekly emails on Tuesdays. Or you can email us at shadowing.h4h@gmail.com in order to also be added to our listserv. Those are all the reminders. Again, if you have any questions, feel free to join us or feel free to email us, and we'll be able to answer any questions you have. But in the meantime, we'll have Dr. Hobbs present. Just give us a second. She's joining back in.
Keep getting kicked out, so.
No worries, Dr. Hobbs. If you want to share your screen and we'll get started. I just laid out the introduction for everyone. So
there you go. Okay, sorry.
No worries. All right, get away.
Okay, so my name is Hannah Hobbs, and thank you, Michael, for inviting me. Can you hear me good?
Yeah, perfect, loud and clear.
So I'm a periodontist here in Hillsborough, North Carolina, and Hillsborough is right outside of Durham. And I just was going to go over my path of how I got to where I am. So I was in a unique program that was a 6-year combined pre-dent and dental school. So I went to 2 years of college and then went on to the University of Maryland School of Dentistry. I'm not sure if these programs are still around, but at the time that I went there, I applied to 3 schools. UCLA, Kentucky, and Maryland had that. And I wound up going to Maryland where I lived. After I graduated dental school, I went on to do a general practice residency in Pennsylvania. Then I was recruited as chief resident at Carolinas Medical Center in Charlotte, and that's what brought me to North Carolina. I practiced general dentistry for about a year, and that's when I met my husband. He got transferred with his job. He worked for Glaxo at the time, and I decided to go back to graduate school to become a periodontist, and I went to the University of California, San Francisco. I got a master's degree in oral biology while simultaneously getting my periodontal residency training. Then I started a periodontal practice in Durham, North Carolina, and a second one in Hillsborough, North Carolina. So more about me, first and foremost, I'm a mother, then I'm a wife, and I'm a periodontist. I lecture nationally and internationally on various topics, including laser-assisted periodontal surgery, which I will show today, treating failing or ailing implants, which is peri-implantitis, periodontal restorative interaction, like taking teeth out, placing implants, doing bone grafts. I started a SPEAR study club, which is a local dental study club with a national connection. And over the years, I've been very fortunate to mentor several pre-dent and dental students. And shortly, I will be teaching what's called in the Academy of General Dentistry Master Clinician programs, where I teach general dentists about our specialty and just to help them understand what periodontics is. So a periodontist is someone who treats gums and underlying bone problems. And 70% of the population has some form of gum disease, whether they know it or not. So periodontal disease is very silent. It's like high blood pressure. If you don't look for it, you don't see it until it's catastrophic, where the patient loses a tooth. Periodontists can do a lot of things. Extractions, bone grafting, soft tissue grafting, implants, crown lengthening, treat failing or ailing implants, scaling and root plating. And we are really considered like the plastic surgeons of the oral cavity. We're very detail oriented, finesse a lot of our work. And fundamentally, we are trained to save teeth. Although implants is a very large part of what I do, but in my core, I want to try to help the patient save their teeth. These are different forms of periodontitis. The American Academy and the European Academy of Periodontists came out with a new grading system in 2018, and these are the different forms of periodontal disease. So periodontal disease can also manifest itself, medical problems can also manifest itself in the gums. So in my career, I have caught many undiagnosed diabetics because diabetes is a collagen-based disorder, and you get glycosylated end products, which decrease the wound healing. So if someone's blood sugar is high, they're going to lose bone around their teeth, and their teeth are going to start being mobile, and you can see it in their tissue. So in my career, I've been able to diagnose someone with diabetes by looking at their gums and doing a clinical exam. So these are the different forms of periodontal disease. And I was just going to go through how we as periodontists measure gum disease. We take a metal probe, and it's broken down into 3 millimeter increments. So 3, 6, 9, 12. And we measure the probing depth, which is how deep it goes to the depth of the pocket. Then we see how much recession there is. So in this demonstration, this patient has 6 millimeters of clinical attachment loss. This person, the tissue is hyperplastic. Now, why would the tissue get taller? Inflammation. They could be on a calcium channel blocker, dilantin, cyclosporine, which are some of the drugs that inhibit rejection of drugs of organs, will cause gingival hyperplasia. So this patient, the probing depth is a 9, but you see that they have 3 millimeters of gingival overgrowth. And so the true pocket is still a 6 millimeter. And in this scenario, the pocket is still a 6 millimeter. You're measuring, it's 4 millimeters depth, but they have about 2 millimeters of recession. So if you add those two, so you can see how you can get different attachment loss by different ways of how the tissue is manifested. So these are some examples. This is necrotizing periodontitis. You see there's punched out papillas. This is just plaque. There's usually a terrible amount of pain, terrible odor. And these people can't brush and floss their teeth because it hurts so much. So for us, we need to go in, numb them up, either do laser surgery or deep cleaning and then conventional surgery, and I'll go over that. So these are some of the periodontal diseases that periodontitis that can be manifested as systemic diseases, the most common of which is diabetes. That is obviously the most common. Patients that smoke will have very hyperkeratotic or very fibrous tissue. In my career, I've caught many neoplasms that are manifested in the tissue. Some of them have been metastases from other areas like the kidney or lung disease or lung cancer. Obviously, anybody with an immune system that's compromised, you'll see, let's say, an HIV or neutropenia, you'll see manifestations of that in the soft tissue. So here's an example of someone that has like a stage 1 periodontal disease. They have clinical attachment loss of 1 to 2 millimeters. And here's where their x-rays, you see the x-rays, you see the level of the bone. They've lost about 10 to 15% of the bone around the teeth. This is someone who has more attachment loss. They've got 15 to 33% of the bone and the soft tissue lost. And so you see here, there's more bone loss, and you're starting to get what we call furcation involvements. And then this is someone that has stage 3 periodontal disease. They have a lot of bone loss, teeth have shifted and moved, and they're likely going to lose some teeth or they've lost teeth due to periodontal disease. And this is what it looks like on an x-ray. And then this is stage 4. This is someone in what we call a terminal dentition, which means they're going to lose probably many or most of their teeth. They can either be replaced with dentures or dentures that are supported by implants, or implants that are underneath here in the gum and show crown and bridge. And I have a case to show. And this is what that person's x-rays would look like. Here's the level of the bone, and it should be higher. So I wanted to talk about laser assisted periodontal surgery because that is kind of a new thing. I've been laser certified for 10 years. So laser assisted surgery, you use the laser to help remove the diseased tissue. So the energy of the laser is only absorbed by gram-negative bacteria or hemoglobin-laden cells, which are the inflamed cells. So it's kind of a new technology. Not everybody has adapted it. Probably about a third of periodontists that are in the academy have a laser. So other things that we do is connective tissue grafting, crown lengthening, ridge augmentation is when you lose a tooth and you're adding bone, and then some implants. I was a general dentist first, so I feel that really helps me be a greater specialist because I know what it's like to be a general dentist having to refer to a periodontist. So I understand both sides of the field, and I feel like that makes me a better periodontist. This is what just a demonstration of what conventional periodontal surgery would be done. Instead of a laser, you measure and then you cut the gum back away from the teeth. You clean the gum, you either add a bone graft or you recontour the gum, and then you suture it with sutures that are closed. So one of the side effects of this is that you have sometimes a lot of sensitivity around the teeth, and then you get recession. The teeth are, you get more loss of tissue, so there's more spaces between the teeth. So the advantages of the laser that I've been trained to use is that it's minimally invasive. There's no suturing because there's no blades to cut with. It's minimally invasive on a scale of 1 to 10. It's about a 1 for being non-invasive, not painful. Most people take ibuprofen or 2. So this is one of the very first cases that I treated in 2011. So as you can see here, the patient has inflammation or redness in the gum, and she was going to get a bridge done. She was a young lady. She couldn't afford to have an implant, so her general dentist sent her to me. And this was literally the first case. This is like a removable temporary that she had to replace that tooth until she got her bridge. And her bridge was going to go from this tooth to this tooth. So I did the laser surgery, and this is what it looks like the day of the surgery. You have this fibrin clot from which the gum goes back and sticks to the teeth and closes up the pocket. And then here she is 1 month later, and it heals. So this is comparison before and after. So the biggest thing with the laser is that you don't get dieback of the tissue. You don't get a lot of recession. The teeth aren't any longer. There's no more tooth structure that's exposed. You just remove the diseased tissue because, again, the energy of the laser is only absorbed by the diseased tissue and the gram-negative bacteria. And the gram-negative bacteria, the bacteria that cause periodontal diseases. And the longer or the deeper the pocket is, the more anaerobic the gram-negative bacteria become, and they more become obligate anaerobes. So they're harder to reach. They're harder to remove with antibiotics, and you just can't put somebody on antibiotics because the etiology hasn't been addressed of the tartar way down in the gum. Here's another case. This is what's called a pyogenic granuloma. You see this a lot in, let's say someone who's pregnant, you'll get gingival growth like this. And then I use my laser to remove it. So this is before and this is after, and you're not seeing any of the dieback of the tissue. It's just removed this lesion and then the tissue came back pink and firm. This is another big case, just a laser, it's a full mouth laser surgery. So this gentleman had not been to the dentist for 15 years. And you hear that a lot in dentistry. People have a bad experience or a painful experience, so they don't go back. So he had not been to the dentist in 15 years because he had had a deep cleaning done and it hurt a lot. So I suggested that we do a laser, and here's his x-rays. As you can see, there's a lot of bone loss. I want to take up this tooth, but he wanted to try to save his teeth. Now, one could make a good argument and take all his teeth out and do dentures, but he was in his like mid-40s. And so he didn't want to lose his teeth. I said, well, I think I can help you buy some time by doing some laser treatment. So here it is the day of the surgery. You see the fibrin clot around the teeth. And He has what's called a crossbite, which means his lower anterior teeth are in front of his uppers, which is not usual. It's usually the other way around. The upper teeth are in front of the lowers when the patient closes all the way. So here he is at 1 month, and you see how pink and firm his tissue is. Now keep an eye on this tooth, because here's what the tissue where it was. So this is before and this is after. And you see he got some growth of the tissue back up. And over the years, I was able to follow him. I lost him to follow up after 3 years, and the tissue continued to stay at this height. So this case is someone who like pretty much defined my career in laser periodontal therapy, because it was such a remarkable change that it gave me more confidence and more assurance that laser surgery does work. So this was, as a specialist, I have a lot of friends that are dentists that text me cases, and my friend is a dentist, and this was her receptionist. She sent me the x-rays, and you see there's no bone around these two teeth. Now what this wire is she's in orthodontic care. You see there's no bone around them. Here's a cone beam view. You see they're literally floating. And the next view, you can see there is no bone around this tooth at all. So I called my friend back and I said, you know, I'm sorry, there's nothing I can do to save these teeth. They need to go. And she's like, please, will you just get her in? So I got her in and I said, look, I see no way of saving these teeth. You have 100% bone loss around these two teeth. Let me get them out. I can do a couple of bone grafts, and I do something called platelet-rich fibrin, and we can talk about that in a question and answer, where you take the patient's blood, I draw the patient's blood, I spin it down in a centrifuge and separate the platelets from the fibrin, and the fibrin has growth factors that you add to the bone, so it helps them accelerates wound healing. It's platelet-rich fibrin is used a lot in orthopedic surgery and in plastic surgery, and just a handful of us in dentistry do this. So I got her in and I said, look, we just need to take these teeth out. She said, nope, I want to save them. I'm getting married in like 6 months. I want to keep my teeth. So I said, okay, well, in order to save them, you're going to have a root canal, because the blood supply to the nerve, which is right here, has been severed. So I sent her to get a root canal, and even though these teeth are splinted with the orthodontic, they're so loose that she can move them with her tongue. So she had the endodontics done, and then I did my laser surgery. Again, I can go through the treatment protocol, but I did the laser surgery. And then because she's in dentistry, we're all busy, I never got to see her for a follow-up. So I texted my friend and said, hey, can you just tell me what happened to her? You know, can you get me an x-ray? So she took an x-ray, and this was 4 months after the laser surgery. You see 100% bone fill around those teeth. I didn't add any bone. All I did was treat the site with the specific protocol with a laser. And you got 100% bone fill. So then they went ahead and took her wire off, and then they connect. Here's the comparison before. There's no bone, and literally his teeth are floating, and you see all this bone. I did not add bone. By using the laser, you're able to photo sterilize the site, get the body's own immune system to help go in there and sweep whatever bacteria is there that are deep-seated and regenerate the bone. And so here she is before. Here she is like 8 months later. Here she is 3 years later. We've had some dieback of the tissue, but of the bone, I mean, but it still looks good. And here she is 5 years later. And I think I had another picture that's 6 years later. So, and she still has those teeth. It's probably been about 8 years now. So we're able to keep these teeth for her. Is it a perfect result? No, but neither would her implants have been, because trying to graft that large a defect is very, very difficult. You'd have to take bone from the chin and put it there, or you'd have to take bone from the ramus. So this bought her at least 8 years. So this case kind of defined my career in laser periodontal therapy. And then I started expanding my treatments. So I had this next case was probably the second case that defined my career because it was the sweetest old man. He was 91. He suffered from multiple myeloma. Multiple myeloma is a cancer of the bone marrow. And the longer the patient has it, the worse off the prognosis is. But most importantly, these patients are on IV bisphosphonate, which retards bone healing and bone regeneration. You also see that somebody who's got breast cancer, who's got metastatic breast cancer, they will put them on IV bisphosphonate. So the incidence of osteonecrosis with someone on IV bisphosphonates, it's about 30 to 35%, which is a very substantial number. So what is osteonecrosis? And I'll have a picture of that. Osteonecrosis is when you get spontaneous death of the bone and it will not heal over. The soft tissue won't close over it. And no matter what you do, it will not heal. Sometimes these patients will have to go through hyperbaric oxygen treatment to get the necrotic bone to slough off and their vascularity to close over and the soft tissue to close over. So this gentleman came in, and this is what osteonecrosis looks like. You see the soft tissue. This patient had nothing done. She had no treatment done. She had metastatic breast cancer, and these were 3 implants, and she was having pain. She went to her oncologist. He sent her to primary care. The primary care sent her to her dentist. Her dentist sent her to me. This white stuff here is necrotic bone. So the soft tissue is sloughing and the bone is exposed. It's super painful. And a lot of these people, as a matter of fact, this patient gets sepsis and they die. So it's a very, very difficult thing to arrest once it starts, especially if they're on IV bisphosphonate. So this gentleman, as I was telling you, he has multiple myeloma. So he was 91, and you see here, he's got a fistula, draining fistula. His tissue is terrible. He's in a lot of pain. And he said to me when he came in, he's like, honey, I really just want to be able to eat. And that was his chief complaint. You know, he's 91. He's got a chronic cancer that's been treated for 7 years. He's not doing very well. He just wants to be able to eat. So I thought, well, let me try. And the osteonecrosis is going on right here, and you'll see the x-ray. Here's some close-ups. You can see why he's having trouble eating. He obviously doesn't brush his teeth because it hurts. So this is the osteonecrosis. You see there, this is the superior border of the mandible, but you see how it's sloughing here. It's radiolucent. You've got little bone spicules coming out. So I said, let me try my laser here. And I asked his son, and his son said, yeah. And I said, I really don't know any other thing to treat him. He had been put on antibiotic, then this rinse, nothing helped him. So this is him the day of the surgery. And this is what you get, that fibrin clot after the 3rd step with the laser. And here he is at 2 weeks. And you can just see the remarkable difference from the 2 weeks before. So I just wanted to show you guys in comparison what he looked like pre-op right here. And then just literally 2 weeks later. What a significant improvement. And I had just done the lower arch. So then after that, I got more brave and I went ahead and did the upper arch. And he went on to do really well for 2 or 3 years, but he ultimately passed away from his multiple myeloma. Lasers can also be used to remove hyperkeratotic areas. So this is a patient I had done several biopsies on, and that's another thing we do as periodontists. We do biopsies in our training, we get about 6 months of oral medicine training to be able to spot cancers, what we call mucoepidermoid diseases, which are like lupus, pemphigus, pemphigoid, and lichen planus. These are all mucoepidermoid diseases where there's it's basically an autoantibody reaction in different parts of the junction of the epithelium and the connective tissue. So I'd done multiple biopsies, made sure this wasn't cancer, and then I treated it with my laser. And here's what it looks like when it's treated with a laser the day of. And then he came in for a follow-up. And as you can see, I left a couple of pieces there. So I just numbed them back up and went in and removed them. This is a case that I just did last Thursday. So this gentleman, I had seen him for several years. He had, this is an x-ray of his lower anterior teeth, which is right here. He had root canals done and crowns on these 2 teeth. And then he had what's called an apico, which is a special kind of surgery that I do and endodontists do. You go in and cut the root off because the root canal didn't go all the way to the base of the root, or it got reinfected. So he had multiple infections from these teeth over the last 2 or 3 years. So finally we decided we're going to take these teeth out, and we were going to go with a bridge because he didn't really have a whole lot of bone width to place implants. So I'll show you, this is the surgery I did last Thursday at about 11:30. So this is the soft tissue. These are the sockets of the teeth, but as you can see here, there's no bone here, and there was no bone here. And these are the teeth removed. And then I placed a bone graft and the PRF, the platelet-rich fibrin. And then here it is sutured on. He was going to go to his general dentist, who is actually a prosthodontist. That's a different type of dentist. And he was going to have a temporary place, and about 6 weeks later, he'd have the final restoration. So the other third of what I do is treat failing or ailing implants. Not mine mostly, but other people's. And implants are very popular now. A lot of people are placing implants, but there can be many, many complications with implants. So this is a patient who was a really high-powered CEO. She had these implants placed, but you can see here, she's starting to get bone loss and recession on this implant. So I saw her, I flapped the area open, made an incision here, used my laser, the erbium arm of the laser, to decontaminate the implant. Then I did a bone graft, the PRF, and then a soft tissue graft. And then this is her result, which is really, really remarkable because this is supremely difficult to do, to try to grow bone and soft tissue around a failing or an ailing implant. This is another case that I did. It's a mother of one of my referring doctors. She has a lot of periodontal disease, and over the years, her teeth have gotten so loose and moved that she had her teeth splinted. So she was at a point where she wanted to have these teeth removed. So what I did was go in, take all her upper teeth out in one sitting, and placed 4 implants. Placed one here, placed one here, placed one here, and placed one here, and did simultaneous bone grafting and that PRF. And here is the x-ray of that day. All the upper teeth are gone, and I put bone in, and then I placed the implants. So this was going to support a bridge. Initially, it's going to be a full denture while the implant's integrated, and then she was going to have something fixed that screwed into the implants. And then here's her final product. This is her final restoration, and she's very happy with it. I just got these photos like last week. So from here to that photo is about 4 months. From my end, I had to uncover the implant, and then you have to send them to the lab. The lab has to process the prosthesis, and everything is done digitally. So it's probably another 2 months or 6 weeks from the lab until you get to this final product. And then this is screwed into the implants. She can't take this in and out, but it's usually taken out once every 1 or 2 years to clean underneath it. But to clean underneath it, she uses a water pick. So we went from that to that. Okay, one more thing, treating failing or ailing implants. Like I said, about a third of what I do is this. And this is an implant that somebody else had done, and the patient was referred to me because the soft tissue was receding from the implant. You see this white thing here? That's not plaque, that's dead bone. So all this is dead bone around the implant. And that can happen for several reasons. In this guy's case, he was an uncontrolled diabetic. His A1C was around 12. Probably not an implant candidate, but nevertheless, the implants were done. Not by me, but they were done. So when I first met him, I said, you got to get your diabetes under control. So talked to his primary care, and then he ultimately wound up seeing an endocrinologist, and he got his A1C down to 7. And that's when I jumped in and did some treatment. So here it is. I opened it up. This white thing, I don't know if you guys can see it. That is the dead bone. That is this. So it's literally just hanging on by the soft tissue. So you remove this. Then I take my laser. This is showing the laser decontaminating the implant. And then I place my bone, which is these little particles, my PRF, which is the platelet-rich fibrin, and then a connective tissue graft, which means I take tissue from his palate and rotate it down and then suture everything. Here he is at like 1 month. Most importantly, here he is at his x-rays. Here he is before. You see all this is lost bone. And then here it is, the bone is regenerating. So the laser allows the decontamination of the implant without changing the manufacturer surface area. We can take implants out, and we do all the time. It's like they do in orthopedics, let's say if a hip failed, but for some reason, patients are not as accepting when something has to be removed and redone in dentistry. They expect that to be redone for free, not like in medicine. But so we try to, especially in this guy's case, this was less than 2 months old, this prosthesis. So someone spends a lot of money and time and pain, and now you're like, hey, I got to take this out. He's not very happy. Just another example of some of the things I do. I took this tooth out on this patient, and it comes out in a million pieces. The reason it does is because root canal teeth are brittle and there's a lot of infection. So they break, and this is how many pieces it came out in. And what I did was I grafted the site, and I put that PRF, which is plasma-rich fibrin. And then here is the view of what the bone looks like after it's healed for about 3 months. And then here is the implant that I placed. And this was done about 2 weeks ago. So we went from all this defect, all this darkness, which is bone loss due to this infected root canal, and was able to grow bone back and have a beautiful implant. It's about 4.8 millimeters wide by 10 millimeters long. So I just wanted to put some, information out there for those that are thinking of going into medicine and dentistry. This is, by the way, my newest hobby, paddleboarding. I love it. And anyway, one of the things that I just wanted to purvey is to always, always, always put the patient first, and the rest will follow. Don't worry about the money. I'm going to nickel and dime this person, because patients can see that. You have to earn their trust. Just because you have doctor in front of your name doesn't mean they're going to trust you, especially in this day and age of Google and WebMD. Everyone comes in with information. And if they don't feel like they can trust you, nothing you say to them will be heard. They will find somebody else that they feel they can connect with. And that is pretty much the most important thing I think I can walk away, tell you now. If you're going into medicine or dentistry, you've got to connect with your patient within the first 10 minutes. There's something that you two have in common, and you have to find it within the first 10 minutes, or else they're going to be sitting there super skeptical. And you can see when people don't listen. So That's very important. If you're going into dentistry and going to own your own practice, you have to manage a business, which is what we do. We're managing a business. We're managing staff. We're managing their emergencies. We're managing their families' emergencies. We're managing equipment breakdowns. So you have to be able to wear a business hat at the same time that you're treating patients. Even if you have an office manager, you still have to be able, you're always looking at where your business is going and how it's going to grow. Be kind to your staff. You spend the most amount of time with your staff, so being kind to them and having their back will help you succeed. And more importantly too, find a mentor. When I first moved to Durham, I found this periodontist that was in another town over, and he was super kind to me. He let me shadow him for many, many weeks, and I asked him a million zillion questions, and I listened to everything he had to say. But I was willing to listen, I was coachable, and I was always trying to learn. I'm still trying to learn. I still take a lot of CE, and I'm still trying to grow even after being in practice for 20 years. I look at my failures and I try to learn from my failures, like what could I have done better? That makes you a really patient-centered provider. And so this is my little family, and this is my information. And if you have any questions, you could email me at this. That's my Instagram account, or you can visit my website. So Michael, I was gonna open it up if you have any questions.
Yeah, well, first of all, thank you again so much, Dr. Hobbs, for coming on over and presenting over the specialty that is periodontics. We do have a few questions, and I want to start with why you specialize in periodontics. You mentioned that you started out as a general dentist and then afterwards decided to become a periodontist. That was something that happened just by the nature of things, by the certain number of years that you were a general dentist, you then decided to become a periodontist, right? So I
was only a general dentist for like 1 year, but I'll be honest with you, I love being a periodontist. It is the most exciting specialty in dentistry. We are the most innovative. It is the most rapidly changing. 80% of what I do now is not what I was taught in residency. It has evolved so much. So it's all about growth factors. It's biomedical engineering. It's just so exciting. It's the most changing part of our field. And I decided to be a periodontist because I loved surgery. And let me back up. I didn't go into medicine because I couldn't take it if someone had died. That would weigh on me. But I loved surgery, and I didn't want to go to oral surgery because the education is like 5 to 7 years, and they do a lot of trauma, and it wasn't for me. I wanted to do surgery, and I love being a periodontist. Now, when I went to residency, it was not as many women because it's a surgical field, but now there are more. And I'll be honest, as a woman periodontist, a lot of other women and men seek me out because they feel that we have a more calm nature. We will listen to them. We are not going to shrug them aside with their concern. We sit and literally listen to them. And so as a periodontist, to me, I still am like in shock that you can take tissue from someone's palate. It's in essence dead, put it somewhere, and it grows tissue. That to me is a miracle. And every time I do one, I've probably done 8,000 grafts. I'm still in awe. It still fascinates me that something like that can heal that remarkably well.
Yeah, definitely is really a blessing of nature. You mentioned dental implants being part of your practice. In medicine, we see like rejection of transplants. Does the same thing happen with implants?
Loaded question. So when I went to residency, I went to school for 3 years to become a periodontist. And part of our training was learning how to place implants. Now there's a lot of people teaching implants to general dentists that maybe go 5-6 weekends a year. So without proper training, implant placement can sometimes not be as well done. So what I'm saying is, would you want your orthopedist to go to 4 weekends, or your primary care to 4 weekends a year to learn how to place a hip in? No, I don't think so. So sometimes when you have some of the general dentists place incredible implants because they don't stop learning. So implant placement has to do, it's a 3-way connection. It has to do with a surgeon, it has to do with the patient, it has to do with the restoration. If any of those 3 things fall apart, the whole thing falls apart. So if the implant is misaligned, malangled, too deep, too facial, too lingual, if the patient, let's say, has diabetes, like that one patient, his A1C was 12. I mean, that's a relative that's not a relative, that's an absolute contraindication for implant. So his wound healing is poor. And then if the restoration, like there's cement around it or something, so yes, there is rejection. It's very, very rare that you have someone who's truly allergic to the titanium in the implant. Now, there are zirconia implants out there. So yes, you can have those placed, but it's about 0.3%. In my career, I've only had one patient who was truly allergic to titanium. And we found that out by getting some lab work done, because every implant I put in rejected and she was allergic to them. So we do get failures. But some of it is technique driven, some of it is patient driven, patient compliance. Also, patients aren't always very compliant. You tell them, hey, that guy that would show you need to get your diabetes under control. So I didn't take his word for it. I called his primary care and I'm like, hey, I need to see his newest A1C, because he thought he was doing great, but his A1C was 12. I mean, that's blood sugar levels in the 500-600. That's not correct. So that was a good question.
Definitely. You mentioned prosthodontists during your lecture. So far, prosthodontists, periodontics, what other specialties are there that people can branch off into?
So there's general dentistry, there's pediatric dentists, they deal with children, endodontists do root canals, prosthodontists do like hard crown and bridge, restoring difficult implant cases. There's orthodontists, they do braces. There's dental anesthesiologists, which put people to sleep. There's periodontists, trying to think, oral medicine specialists. But the last one, these people practice at like a hospital, not a hospital, like in a university setting.
And I see a lot of these oral and maxillofacial surgeons sometimes having MDs, sometimes having DMDs. Could you explain why that might be?
Okay, that's a great question. So I forgot, that was another specialty, oral surgeons. So oral surgeons, until about, I think 12 years ago, could go on to dental school, then do oral surgery residency, which was like 3 to 5 years. But they made a CODA, which is the accreditation body, said they had to go to medical school too, because they're going to be doing his H&Ps on patients, admitting patients. So every oral surgeon that has graduated 12 or 15 years forward has got an MD. So they go to dental school, then they go to like a year or 2 of medical school after they start their oral surgery training, and then they go back to their oral surgery training.
I see. All right, that's great to explain. You mentioned approaching a patient. A lot of them don't necessarily, they might just, coming into the visit, have distrust for the dentist that's in front of them. This applies to really any healthcare profession. And some people might even just generally have a fear of needles, or especially in this kind of specialty of surgery, being invasive. How do you overcome that? How do you present yourself kind of calmly and just, like we would say in medicine, present them well with your bedside manner?
So I think, I gave you the biggest trick. You have got to find something that you're having common with them within the first 10 minutes. And so when I see a new patient, I don't sit behind them. I don't stand above them. I sit in front of them, face them. And I'm like, what brings you here today? And I let them talk. Then I start taking notes. And the patient needs to feel like they're heard. Like when I go to the doctor and if they're talking over me and they're not hearing me, and I'm like, this person's an idiot. They're not listening to anything I'm saying because they're already responding. So you want to let the patient talk, find out why they haven't been to the dentist in 15 years. Maybe they were having a tooth worked on and it hurt a lot. And the dentist didn't believe them and just kept going. Maybe they're scared of needles. There's many ways to overcome that now. You can do enzeolysis, you can do sedation. But if you just communicate with the patient and have them understand that, hey, I hear you and I validate what you're saying, I understand, and this is what I'm going to do to change that going forward. Like that one guy, he hadn't been to the dentist in 15 years because when he had the treatment done with his original dentist, not a periodontist, but original dentist, it hurt during the procedure. He told them, they didn't believe him. They said, oh, you're making this up. There's no way. Well, we don't have the luxury in dentistry to put people out, like orthopedists. Have you ever been and seen any orthopedic surgeries in person? It is brutal. But the patient's unconscious. They don't know. They don't know that they're using a saw and a hammer and a chisel. We hurt people and ask them to cooperate a lot. Once you get a person numb, hopefully they won't feel anything. But sometimes, you have to give more. You have to do sedation or enzeolysis, and that's all in our tricks.
You also took an accelerated program with college and dental school. That's not necessarily like always being the path. It's not necessarily always the case, but for the people who would like to consider going that route, what would you suggest?
I was 21 when I graduated dental school, which was ridiculously immature. I look back and it's, dental school was not as hard as college, because in college I carried 90 credits, 25 credits per semester, 25 or 26. So we had the summer before, summer between, summer after. So I had gathered, over 90 some credits to go to dental school. And in my second year of dental school, I got my undergrad degree. Would I do it again? If I was a seasoned person, if I had been, let's say, an engineer and I went back, yeah, but going right out of high school, I think there's just a level of maturity you get with time, and you won't get that by shaving those 2 years. Yeah, I got 2 years ahead, but I was so immature when I graduated dental school. That's why I went on to do all those other residency. I did a general practice residency at York Hospital. Then I went to Carolinas Medical Center. Honestly, dental school compared to how intense college was not that bad, because carrying, just imagine you carry, I don't know if you're in college, Michael.
Yeah, I'm a senior right now, graduating soon this summer.
Nice. So just imagine carrying like 25, 26 credits.
Mm-hmm. That's a lot.
It's a lot. It's a lot. And, you're running from one end of the campus to another. So I think there's a few programs like that. I'm not sure. I think, but it's, you really have to be laser focused, super organized, learn how to take notes, because there's an art to that, learn how to test properly. But if I had to meet myself, I would say no, don't do it again. It's the 2 years that you spend living life is so much better than rushing through it.
Definitely. 25 credits is quite a bit for one semester. Usually people take around 30 credits in a whole year. So yes, that's quite a bit. You mentioned the specialties that you have within dentistry, extending outside of just general dentistry. Which ones do you particularly work with the most?
That's an excellent question. So I work with, I'm super fortunate. I've been at it long enough. I have some great restorative doctors, just general dentists that I work with, young and old. And they refer to me. Probably the next specialty that I work with the most would be like an endodontist, because a lot of gum infections can be mimicked as a root canal problem and vice versa. So the patient will be sent, hey, we don't know if the etiology is endo or perio. Can you help us rule that out? Or is it a fractured tooth? Then it would probably be prosthodontist, which is the person that does the complex restorative care. And then then next would be orthodontist, where you get a lot of recession, the gum received during ortho or before ortho. But I work mostly with really great restorative doctors that recognize the importance of having a collaborative working relationship with a specialist. They don't try to do everything. They do some things, but when it's outside of their realm, they refer out.
Outside of just being a periodontist for so many years, you're also an assistant professor along with that. So you incorporate teaching, right, with your day-to-day work. How do you like to go about teaching? What motivated you to get to that side of dentistry?
Well, I think once you've been in dentistry long enough, you want to give back. So not only do I teach, but I volunteer my time, for the homeless clinic. I mentor a lot of younger dentists that are coming up, and it's just awesome to see these people then graduate from dental school and come around the corner and practice for me. It's very satisfying. When you've been at something long enough, you want to give back. And that's one way of giving back. The thing I love the most too, we see like patients that go to Wake Smiles, which is an indigent clinic. I see them in my practice. We just do all their work for free. And then once a month, I see a veteran for free, because even though they may have benefits from the VA, it's just too much to deal with. We just do the work and we write it off. Again, you've got to give back to the community that you're in.
Definitely. There's a lot of experience to be given that way. Another thing I wanted to mention is, and we oftentimes will mention this for specialties in general, is how students now, mainly being in college, some being in post-bac, but none of them really being to the point of graduate school, how can they get involved in a specialty like periodontics? How can they, I know it might be difficult given that they're just college students, they haven't even entered a phase of dental school, but past shadowing, what can they do?
Well, I was going to say shadowing. Like tomorrow, we have a guy who's coming in. He went and shadowed a really good general dentist friend of mine, and he wanted to look at some of the surgical specialties. So he's coming to work to stay with me. I would say go see your general dentist and just spend a day with your general dentist, and then see like what they do, the pace. So dentistry, especially in private practice, is very different from medicine. You are constantly pivoting to change. Like your schedule will say one thing, then something happens. Person A is late. Person B has a problem with another tooth. So you're constantly pivoting. You're managing time. You're managing expectations. You're managing staff. You have to be able to pivot all the time. It never goes according to, it's rare, but it goes according to the flow that you have of the day. So seeing that, if you're the kind of person that can think on your feet, resolve problems quickly, dentistry is a really great field. I will say, I think if I had to go back, I love being a periodontist, but I would just stick with general dentistry because the cost of education is so insane now. Like dental school is ridiculous. And then specializing on top of that, it's very high.
Definitely. Right now, you're in North Carolina and have been practicing for a while there on the East Coast. Does practicing look different from one coast to another, or in a more rural versus urban area?
That's a great question. So I went to graduate school in San Francisco. And all my classmates, every single one of them was from California. I was the only East Coaster, and I was the only one that moved away. I think, I'm lucky. I don't take any insurance in my practice. I'm what's called a fee-for-service practice. So I can pretty much set the time that I want to spend. But if you're in a heavily insurance-driven practice, you have so much you have to see to meet your overhead, because your fees are reduced by a certain amount. So California there's a ton of dentists, tons of regulation. If I was to go to dental school and graduate today, I would go practice in a rural area, hands down. There's a tremendous need, and people don't want to move there. Instead of like here in Raleigh, there's a road, Falls of the News. There's probably 150 dentists on that road between all the specialists and general dentists. Yeah, I mean, you can eke out a living, but you have to differentiate yourself. But if you're in a rural area where, let's say in Henderson, North Carolina, there's 5 dentists, you would do pretty good. So if it was me, I'd move to a rural area. But that's the thing, the draw of the big city is why people want to live, because they want to go to restaurants, stuff like that. But rural areas, there's a tremendous need.
Definitely. One more question, I think we'll wrap up today's session. So through your training, you mentioned in taking an accelerated program, it rushed through the process a lot, and looking back, you would have done it differently. But outside of that, reflecting on the whole training process, including college, dental school, residency, and specialization, are there any other things that you would have changed?
That's a great question. No. I'm where I am now because of everything that I went through. So no, I don't think I would have changed anything about my career. I love the path that my career is at now. I'm in private practice. I teach, I lecture a lot, and I'm getting asked to lecture more. I think, let me put it this way. One of my mentors in grad school, this is in California, he had a super successful periodontal practice. As a matter of fact, Steve Jobs was his patient. And he sat me down and said, Hannah, don't get big. And I'm like, what do you mean by that? He said, when I had just 4 employees, I was super busy and super profitable. Then he grew to 30 employees, and his overhead grew up. For example, he said his payroll was $300,000 a month. So you have to generate a lot of work to pay your payroll. So he told me, don't get big. It's not worth it. Stay small, stay true to your value. And that's what I'm doing now. I do one thing at a time. I see one patient. I am booked out through the end of August. Patients have to wait a long time to come see me. And when they come, I said, I'm sorry. They're like, it took us a long time to get it. I said, I'm really sorry, but I do one thing at a time. I see one patient an hour. Even if we're not doing anything, we're just chitty-chatting, I still see that one patient. And that is the path that I've chosen for me. It's not for everyone. People want to add more patients, jump from room to room. But for me, it's not patient-centered care. It's not for me. So if I had to do anything, it would just stay small, stay true to my value, get to know your patients, live in the community that you're going to practice, whether it's medicine or dentistry, because it's really important. When they see you at the store, they're like, oh my God, I didn't know you went to the grocery store. I'm like, well, I don't have someone that shops for me. My kid goes to school with some of their children. The teachers are my patients. The principal's my patient. Live in a community that you want to practice in, become involved in the community, stay true to your core values. Again, I know people have debt and money, but live within your means. That is something my husband and I did when we first got. Live within your means. You don't have to buy the fanciest house and this and that. Everybody wants to make money, but if you just be patient and have a long-term view, you will be super successful.
I think that's a perfect way that we can wrap up today's session. I don't think we could end it any better, to be honest. But thank you so much again, Dr. Hobbs, for joining us.
Thank you. Michael, what's your major?
I'm a biomolecular sciences major.
Ooh, where do you go to school?
I go to a public university in Connecticut. It's in the New Haven area.
Nice.
Yeah. And just a few reminders for our shadowers before we do end. To earn credit for your attendance, you must pass the quiz, which is now posted in both the chat box and also on our website. If you navigate to the virtual shadowing page, just scroll a little down, you'll see shadowing quiz, Dr. Hobbs. Click onto that and you'll be able to take the quiz. That quiz, you need to pass with 60% or higher, and it's due by 11:59 p.m. Central Standard Time on this upcoming Sunday, July 24th. As a general reminder, we do have different days for shadowing. So Mondays and Thursdays are our main ones, but just generally, you'll find that the quiz deadlines are 6 days after that session date. So that's just the general timeline. But for this one specifically, it's going to be 11:59 p.m. CST this Sunday, July 24th. After passing that quiz, you're going to receive a certificate, which will be sent to the inbox of the email address you list on that quiz. Although if you don't find the certificate, please check your spam folder. I also recommend that if you're going to be using an email, try to use a personal email. Sometimes school emails will filter out things like this. So a personal Gmail, Yahoo account would be much better. For our next shadowing session, we're going to be joined this Thursday, July 21st at 7 p.m. Central with Dr. Plenty for another shadowing session this week. Again, a reminder, usually Mondays and Thursdays, we're now opening shadowing sessions too. So 2 shadowing sessions instead of the 1 that we usually had in the spring. And again, if you want to stay tuned with all of the future shadowing sessions we have, feel free to follow us on Instagram and subscribe to our listserv where you're going to be in the loop with more updates. Other than that, Dr. Hobbs already has her Instagram handle here, her email here, her website, which is perfect. So do you have any last words you want to throw out there, Dr. Hobbs?
No, I really appreciate you getting my opinion, and I wish everyone luck. Just continue working hard and dream big. Change is hard, but staying the same is even worse.
Those are some great wise words to end on. All right, well, hope everyone has a great rest of your night, and